since she's videotaping.
Okay, you're on.
So, okay. Okay, all right, I'll be good. I'll be good.
Be on your best behavior.
I make no promises. All right, we're gonna talk about restraints. Restraints is the #1 reason hospitals get type 1 deficiencies from the Joint Commission. Every time the Joint Commission has been here, we have gotten a deficiency for restraints. Are we gonna get one again? Yes. I'd like to tell you no, but we are, because we can't seem to get restraints right. We do restraint training all the time. I tell y'all to call me if you have questions, but we screw them up every single time, it seems like. And there's always seems to be something a little bit different. And it's not just us, it's the doctors as well, because for smart people, they can be really damn stupid. And I do the restraint training for them as well, okay? I meet with them one-to-one, I go to med staff, but they still screw up their orders. And so we as nurses sometimes have to watch out for our doctors. If you have a patient who needs to go in restraints, they can be placed in restraints by a specially trained nurse, which all of you are now, okay? So if a patient is aggressive, out of control, and clearly a danger to themselves or others, feel free to put them in restraints and then notify the doctor. If a patient, you know, you're putting them on a vent, they're interfering with treatment, they're pulling out their IVs, they're just all over the place, put them in restraints, notify the doctor, okay? And then what are you gonna do?
Print out the packing.
Okay, you're gonna get an order, either a verbal order or have them write it. Who works in the ER? Okay, so those of you in the ER, if you get a verbal order and you have that patient in restraints and then you do your documentation, go back and look at the physician's orders. Because sometimes I come in and you've had a patient in restraints and guess what? There's no order. Because you guys assume that the physician is putting it in. The physician assumes that you guys are putting it in. And in the meantime, nobody's putting it in and Melanie's having a heart attack on the next morning. I'm like, what the heck? So make sure there's an order. Make sure the order is put in correctly. In order to put in an order for restraints, everybody knows how to do it, right? You go to your CPOE. If you just pick, type in restraints, and your little box up here says all order types, you're gonna get all of these. Wrong, okay? Make sure you choose order sets, okay, instead of just all. And then when you type in restraints, you're gonna get one, and one only. Makes it a lot easier for you, okay? And what it's gonna look like is this, which you can barely see because this screenshot is really small. But basically, it's going to look exactly like the pre-printed orders that I have had made for you. If you don't want to put it in through CPOE, put it in through the printed order, okay? You can print this out of order management. You all know how to find this. It's just labeled restraint order. It's real easy. Because sometimes you don't realize that, oh, dang, we forgot to put that order in, and you put that patient in restraints at 11 o'clock at night, and it's 6 o'clock in the morning, and you're checking, and it's like, oh, we forgot to put that order in. And then what happens? Then what do you guys do? You come back and you put the restraint order in, but you forget to change the time. So now I have a restraint order for 6 o'clock in the morning, but I don't have one for 11 o'clock at night when the patient went in restraints. So don't do that. If you forget or something like that happens, print your order, put in the time that you actually got the verbal order, okay? In order for a restraint order to be legal, it has to have 3 components. It has to have the reason for the restraint, either behavioral or medical. It has to have the type of restraint, wrist and ankle, or the mitts, okay? If you mark wrist and ankle, most of the time, that is a behavioral health restraint and needs to be treated as such. Unless there is clear and concise documentation that that patient is interfering with medical care with their feet, which can be done, you know, if they're pulling out at their Foley, if they can really, you have some people here who are really quite limber. Not me, but some of them. So, the type of restraints and the length of time. I have it spelled out for you pretty clearly. Medical restraint is good for 24 hours. Behavioral health restraint is good for 4 hours for an adult, 2 hours for a child ages 9 to 17, 1 hour for a child under the age of 9. So, if you have a patient in behavioral restraints, you want to get that patient calmed down pretty darn quickly, right? So you're going to give them some medication. You're going to give them some Ativan, some Haldol, some Benadryl. You can mix those in the same syringe, give it to them. I know you guys call it a B52 down there, give it to them. You want to get that patient calmed down pretty darn quickly, okay? Because you want them out of restraints in a reasonable time. Number one, because this is what we usually get dinged on. Number two, it's a lot easier. You won't have to do all the paperwork. Number three, you're going to get that patient in and out a lot quicker if you can get them calmed down, right? 90% of our behavioral health restraints are in the ER. The other ones are usually up on med-surg because of the ER. So there's ER holds up there. And these are the ones that we usually screw up the most. Medical restraints, most of them are in the ICU. So if you have questions about restraints at any time, give me a call. My number's posted in the ICU, med-surg. You can get it from the nursing coordinators. Even if you work nights or weekends, I'll answer my phone and I'll walk you through how to do restraints. All right? Questions? Okay, that's simply the order. So then, after you put the patient in restraints, what are you going to do? You've got the order, and then what?
Assess the patient.
Okay. Well, hopefully you assess the patient before you put them in restraints, but you're going to start the flow sheet. Okay, open the daily assessment, okay, and click on the restraint flow sheet. That does a couple of things. Number one, as soon as you mark anything on that tab, it puts them on my list that I am required to provide to the Joint Commission. Joint Commission comes every 2 to 3 years, and I have to provide them a list of every patient who is in restraints since the time they left. And then they get to pick and choose which charts they want to look at and which charts that we have to sit down and defend. So it is my job to defend your charting, and sometimes it's really hard. So help me out, okay? Makes it a lot easier if you do things right. So we're going to talk about how to do things right. You're going to open that daily assessment. You're going to fill out as much as you can. Just because there are boxes there doesn't mean something has to be marked. Okay? You've already done, you've got your order. You're going to put what time the patient went into restraints. You're not going to be able to mark what time they came out. You're not going to do a range of motion. There's other things on there that you don't have to mark, but mark as much as you can. Mark your criteria for being placed in restraints. There's a box on the left-hand side of that screen. On the top is a medical box, and right below that is a box for behavioral health restraints. You're going to mark one or the other, not both. It's either medical or it's behavioral. If it's a medical restraint and you filled out that first box, and then you come along and you mark that they are a danger to themselves or others, bingo, you have just made that a behavioral restraint, and that order is now good, only good for 4 hours, and you're going to have to document like behavioral restraint. Don't touch that box if it's a medical restraint. Does that make sense? All right, so that puts it on the list. That also flags me. I get a little thing off of my my fax machine that says, Lexi was in restraints in ICU last night. So let me go see if they did things right. So then I can come over and I can see that, oh shit, we don't have an order, or whatever the issue is. So make sure you open that tab. Usually it's a lot easier for medical restraints to then go to the paper flow sheet, especially for if we think they're gonna be in it for any length of time. When you're looking for this sheet is under order management. It's called restraint flow sheet. So it's pretty easy to find. Print this out. There's also files on just about every unit. So print this, fill it out. The one thing people always forget is the date. I know that's hard, because when you computer chart, it's always printed there for you. But fill out the date, initial and sign at the bottom, and then everything that is on here is the same that's on the restraint flow sheet. You've got your range of motion, you've got your capillary refill, you're assessing skin color, position, skin temp, that you offered them nutrition, that you've offered them a toilet break, that you're doing all of these things at least every 2 hours. Not 2 hours and 1 minute, but every 2 hours. And that's why we've gone to paper, because it's hard to get back into the computer at least every 2 hours. You might be a few minutes late, right? You might have been in that room taking care of the patient, and you might not get back to the computer, and then people forget to change their times, which is why we get dinged, because we're late on our assessments, even though we've done them. So switch to paper. It's easy to keep in the room. The one thing, yes, and this needs to be done by a nurse. This is a nursing assessment. I have seen these done by CNAs. These cannot be done by CNAs. These are nursing assessments. This is your responsibility. It is your patient. Complete these, okay? The other big thing that I'm seeing a lot is you take the patient out of restraints and you just stop the flow sheet. So if the flow sheet was stopped at 1400, what time did that patient come out of restraints? You weren't supposed to document again until what? 1600. So sometime, I have no freaking clue what time that patient came out of restraints. And I don't care where you document it. You can go back to the flow sheet on the computer and put that time in there. You can do it on your next assessment. Patient was taken out of restraints at 1500. You can put it in a progress note. I don't care where you put it, just put it somewhere. A lot of people just like to write across it. Patient removed from restraints at whatever time, and that's fine. Whatever is easier, just put it somewhere, okay? So while you're doing those, you're gonna have to do these on both the medical patient and the patient in behavioral restraints. If you have a patient in behavioral restraints for 10 hours, an adult in restraints for 10 hours, how many orders are you gonna have to have?
2 orders?
Mm-hmm.
You said medical restraint?
Behavioral restraints.
Oh, 2.
Okay, so at 4 hours, you need to get another order. So behavioral restraints, you put that patient in restraints, you notified the physician. The physician has 1 hour to come and see that patient. Usually, since those are in the ER, we're good, because the physician's right there. Up on med-surg, if we put a patient in behavioral restraints, we have 1 hour for an ER physician to come up and see them. If it's a patient of one of our docs and they give us the order, then we try and get them in. What are the odds of them coming in at 2 o'clock in the morning? Slim to none. So we need to call the ER. We pay them to cover our patients. They can come up and do that face-to-face. If for some reason they won't, or they tell you no, then call me, and I will call them, okay? Because they have to be up there, because otherwise we have to take that patient out of restraints. So you put the behavioral health patient in restraints. You also have to do this at least every 2 hours. It's a little bit easier on the behavioral health patient because hopefully we're going to get them out of restraints and you'll only have to do this one other time, okay? But remember, it has to be done at least every 2 hours. They are your patient. You have to assess them, even though we have a CNA or a security guard or somebody sitting with them, right? So they're usually the ones who are doing this because on behavioral health patients, in addition to the 2-hour nursing assessment, we are required to do an every 15-minute behavioral observation. This is what this form is. This is under order management as well. So the very last form down at the bottom, it's called 15-minute check sheet, I believe. But this can be done by the CNAs, this can be done by security, this can be done by your sitters, whoever is sitting with that patient. And this is simply a behavioral observation. This does not take the place of this. The CNA and security is not responsible for your patients. Security can't take that patient to the bathroom. Security really should not be laying their hands. They are doing nothing but the behavioral observation. They are still your patient. Make sense? So, our goal is to get the patient out of restraints and as soon as possible. If we have a patient in restraints in ICU and we've got them on a vent and then they are no longer responsive and we're coming along and we're documenting the patient is non-responsive, they're not moving at all. Why do we have them in restraints? Are they interfering with any care? Okay, no. So, take them out of restraints. A lot of people have said, well, what happens if as soon as you take them out, then their hands are going for their ET tube or their hands are doing something? It's like, okay, do you document that? Not very often. So, If you have a justification to keep them in restraints, you can keep them in restraints. You can keep a vent patient in restraints for 24 hours, but if you're removing their restraints every 2 hours and giving them a range of motion, and every time you give them a range of motion, they're going for a tube or something, document it. Give us justification to keep that patient in restraints. Does that make sense?
So if you have a patient that's not doing that, and you take them out of restraints, but say 4 hours later, they start going for those tubes again, do you have to call and get a whole new order?
You do.
Okay.
Yep.
So if you document that you DC'd them because they were
Yep.
not doing those things.
If you take a Foley out, do you have to get an order to put it back in?
Yep.
Yep. It's the exact same thing. If she's in restraints and her family comes in and says, you know, hey, I'm gonna be sitting here with mom all day, you can take her out of restraints, I'll make sure she doesn't grab anything. Great, that's fine. We'd love to do that. So we take her out of restraints, and then the granddaughter has to go. When she leaves, if she starts messing with things and we put her back in, we need a new order. You can take a patient out of restraints for 15, 20 minutes, 30 minutes max. But you can take them out of restraints to walk them to the bathroom, to maybe feed them, to, are they following directions? Are they a little bit clearer? Let's take a walk or whatever, and put them back in restraints. Because that, you can document that as your range of motion. You can also document it as your nursing assessment. Are they able to follow directions? Are they a little bit more coherent or whatever? But if you take them out to see how they're going to do, that means that restraint has stopped. You need a new order, even though that original order was good for 24 hours. Does that make sense? Okay. Everybody knows how to put the restraints on. Everybody has seen them and played with them, know where they are on every unit. They're very comfortable. They're easy to put on. It used to be we had to do those quick release ties, which nobody could remember how to do. So these are all clips now, making it really easy on you. Like I said, they're comfortable. Ever since that movie 50 Shades of Grey came out, my restraints keep disappearing. I don't know what you guys are doing.
Oh man.
Anyway, so the blue is the wrist. They have 2 straps. When you're putting these on, they're on the beds in ICU and med-surg. There are specific places for them. For those of you down in the ER, we're going to come down and play with your beds because you have different kinds of beds. So we're going to come down and play with them and figure out where the best places are. If you have a little old lady or a confused patient who just needs reminders, okay, putting them down, both arms down at the side of the bed is perfectly appropriate. But if you have a violent and aggressive patient or a patient who is really agitated and moving around, put one arm down at their side, put the other arm up. And then when you do your range of motion, switch them. On the beds on med-surg, ICU, do not attach the one that's up to the headboard because the headboard comes out. Okay, there's a bar back there where you can attach it, and that keeps them from coming up off the bed a lot more. All right, ankle restraints are red. They're a little bit bigger. These only have 1 strap. So you're going to strap it to the side of the bed. You're going to strap that one to the side of the bed, and what's going to happen? The patient's going to walk by, or you're going to walk by and that patient's going to kick the crap out of you, right? So cross those and then hook them. Okay? You can always, if you're in a hurry, hook these together. The only problem with hooking them together is it's a temporary fix because if they're able to move their legs a lot, they might be able to get that Velcro open. But that would be a temporary fix if the patient is really agitated and aggressive. Questions? No? You guys are perfect on restraints?
Until something crazy
Huh?
happens and I'm calling you like, no.
And you know what? Call me.
That's what I do.
And that's fine. Call me because I will walk you through it. And yeah, and don't be offended if you get a note from me the next day, or I'm calling you, or I'm making your supervisor call you. Hey, come in and fix this, because it's a whole lot easier to fix it in real time than it is later on down the road. And if there's something that you don't understand or you're not sure about what needs to be done, call me because I can walk you through it. I'll answer my phone on weekends, holidays, whatever. But let's get it right and see, it would be really nice not to get a deficiency on restraints. Care plans. That's the other thing, sorry. No, I was forgetting something. Care plans have to be done on every patient in restraints. That is what we got dinged on last year. When you open that daily assessment before it closes, hopefully, if it works right, it's supposed to ask you whether you've done a care plan. We have a restraint care plan built. Open it. Okay? That's the one thing we're constantly missing. So, yeah, care plans. I know people don't like them, but they have to be done according to the Joint Commission and CMS. All right, children. Go for it.